Good afternoon and welcome. Thank you for joining us today. My name is Claudia Trevor-Wright and I am the Special Projects Coordinator for the Best Practices for Sexual Health Promotion and Clinical Care in College Health Settings Toolkit. Today we will be reintroducing the best practices for sexual health promotion and clinical care. This webinar is sponsored by Hologic Inc. Because of their support, we're able to bring this educational content to you today at no cost. However, there are no continuing education credits available today. At any time during the presentation, you may type a question into the Q&A panel at the bottom of your screen. We have a lot of excellent content for you, but we should have some time for some good Q&A at the end. The webinar will be recorded, so for those of you who are registered, you'll receive a link to the recording later. And I am pleased to introduce today's speakers. Joanne Brown is the past chair of the ACHA Sexual Health Promotion and Clinical Care Coalition and a nurse practitioner at the University of Kentucky. Blake Flaugher is the current chair of the coalition and a sexual well-being health promotion specialist at the University of California, Davis. Brandy Reeves is secretary of the coalition and the director of the Student Wellness Center at the University of Cincinnati. Today, we'll be reviewing the best practices in the same way that they're laid out in the document itself. We'll talk about the shared responsibility areas, then what is unique to health promotion, and of course, clinical practice. Then we will preview the implementation toolkit and the next webinar in this series, which will take place in November, and of course, leave time for Q&A. And with that, I'm happy to turn it over to Blake.
Thanks, Claudia. Hello, everyone. Really good to be here. Thanks for joining. Next slide, there we go. So ACHA turning 100, already turned 100. So happy birthday, ACHA. It's really cool to see how far that college health has come. Not that I've been around for 100 years, but yeah, super exciting things are happening. So hopefully we'll all get to see each other next June in New Orleans. Next slide, please. So going over the guidelines, if you're not familiar with them, so these were developed over a 1.5-year time period by the Sexual Health Promotion and Clinical Care Coalition. They were published in January of 2020, and they focus on sexual health through the lenses of public health and medicine. So that is what we're going to focus on. They do include a lot of implementation resources and citations. We tried to be as thorough as we could to make sure that people had the tools for, organizational development and really practice good health promotion and clinical care when it comes to sexual health. So today, rather than recite what is in the document, because there's a lot in that document, so again, please read it. We want to talk as much about COVID adaptations and answer your questions as much as we can. So that's what we're going to try to accomplish. And so we'll take some questions at the end, and now I'm going to pass it over to Brandy.
Thank you so much, Blake. I'm going to start talking about shared responsibility, which are the things that everyone in the health center can do, whether you are a clinician, whether you work at the front desk, whether you are a health promotion specialist. Next slide, please. One of the things that we think that you should do, and that's included in the best practices, is to incorporate pleasure and intimacy into the work that we do around sexual health. We know that sexual health is so much more than just prevention of infections and pregnancy. The World Health Organization actually includes pleasure in their definition of sexual health. And so we really want to make sure that students understand that and get that education that they need. Some things that you can do, some examples of ways that you can include pleasure and intimacy into the work that you do would be to offer a variety of condom sizes and styles. We know that if condoms feel good, that people will be more likely to use them. And so having condoms that fit well and that feel good can help to increase use. And then lubricant is also a really great way to help to increase pleasure in general. But then also if we're thinking about using condoms and other barrier methods for STI and pregnancy prevention, then lubricant can help to make that feel better and make that more pleasurable. affirming to students who are recently diagnosed with an STI, including HIV, that they can and should and deserve to have pleasurable sex, and just sex in general is another thing that we can do. So having a separate conversation, or, you know, as part of that diagnostic conversation about pleasure and intimacy with those students, that's an example. And then finally, discussing safer sex and reducing the risk of COVID during telehealth visits. And I'm going to talk more about that here in a couple of slides. Next slide, please. Creating a welcoming environment is something that everyone can do. It starts at the front desk, and even maybe before that, as you're walking into the lobby, as you're walking into the Student Health Center, making sure that the messaging and the materials that are provided are inclusive, that they're affirming, that they're positive, that they're sex positive, that we're using gender neutral and gender inclusive language and terminology, and then also having calming designs to be mindful of students who may have experienced trauma. And I'll talk more about that in a future slide. Some examples of things that you can do in the health center would be to include your pronouns on staff badges, business cards, name badges, those sorts of things, to help to normalize the use of pronouns, as well as to help to make our students feel more comfortable. You can also do that in, like you see here, all of our names, we have our pronouns included, so you can do that as part of the presentations and webinars and things like that with students. Providing safer sex supplies in the lobby or other high trafficked areas and bathrooms, those sorts of places, to make them really easily accessible. And then training everyone on the use of inclusive language. Next slide, please. The reason why we want to make sure that we're using inclusive language are for all students, but especially for our trans and non-binary students. We want to make sure that the services that we're providing, the medical care, the language, everything that we're providing is inclusive and takes these students into consideration. Some things that you can do, having gender inclusive restrooms, if you're able to do that in your facility, or even like single stall bathrooms, those are gender inclusive, restrooms as well. And making sure that when we talk about trans and non-binary care, that it's not just about sexual health, because our trans students might not even be engaging in sexual activity. And so we don't want to sort of put them in this bucket or stereotype them in, the world of sexual health. So in making sure that we're including trans and non-binary care during primary care visits as well. And there's a list of trainings here at the bottom of opportunities that you can take advantage of, whether you are a clinical staff or a health promotion specialist, or really anyone at the Student Health Center. These trainings are going to be good for anyone to take advantage of. Next slide, please. And then also, as part of making sure that we're providing welcoming environments and trans inclusive healthcare, is to collect SOGI data. And SOGI stands for Sexual Orientation and Gender Identity. If we don't collect data about these students, then they're invisible. And so we want to make sure that the data that we collect helps us to understand all of our student needs, including our LGBTQ+ students. You can see a list here of explicit fields to include in your EHR. And one thing that I want to note is, I know at my school and at previous institutions, the data that comes into EHR came from the student records. And sometimes the student data might not reflect students' identity. It might not include things like pronouns. It might not include their lived or chosen name. And so including those fields specifically in your EHR can help to make sure that the care and the services that you are providing are inclusive. So adding those fields if it's not brought over in your student data. Some other things that you can do as part of trans inclusive and LGBTQ+ inclusive care is to have a two-step question to ask about gender identity. And just quickly, what that looks like is to ask what sex you were assigned at birth, as well as to ask what best describes your gender identity. That research shows that helps to make sure that the information that you are getting and the data that students are providing is accurate, just in case there might be confusion with asking the question or answering the question. So that just helps to really make sure that the data that we're collecting is, is accurate and best reflects our student needs. And there is more information about that in the best practices document. Again, asking students what name and pronouns they use, and then if you're not sure, just deferring to they, them to make sure that you're being as inclusive as possible. Next slide, please. And then I talked earlier about a trauma-informed approach, making sure that we are taking into consideration the fact that some of our students might have experienced trauma, and we don't know who those students are. It's not always obvious. It doesn't always come up in a clinical visit. And so treating all students the same and just assuming that all students have experienced some sort of trauma can help to make sure that we have a welcoming environment for all students. It also helps to establish rapport and trust. And that might look like having a chaperone in the exam room during those sensitive exams. During sexuality education, when you're doing outreach on campus, that you're establishing group agreements and group guidelines at the beginning of the presentation. And then also making sure that you are reviewing the agenda or the content of the presentation before you just jump in and talk about sexual health or, other things that could be sort of triggering for students, because then that way students know what to expect, and that's part of establishing consent and really wanting to normalize consent. Next slide, please. And then confidentiality is so important. We want to make sure that students understand what their rights and responsibilities are in terms of confidentiality. So thinking about health insurance and the explanation of benefits, if students are on their family's insurance plans, some students might be concerned about coming and having sexual health services done at the student health center because they might be worried that their families will find out. And that obviously can create a barrier. And so providing free or low cost services for students so they can not use their health insurance so that they don't have to worry about that is one option. Educating students about insurance and confidentiality laws, especially what might apply in your state. So for example, Blake is in California, and there's a website you can see at the bottom of the screen, myhealthmyinfo.org, where students in California can actually have their explanation of benefits sent to them as the individual as opposed to the policy holder. So that helps to address some of those confidentiality concerns. So making sure students know that and educating them about that. And then also potentially listing charges generically. A student who is told that their visit will just say student health visit might be more likely to come back or to seek care as opposed to having it say something like HIV testing or birth control visit, especially when they know their families might find out. Next slide, please. And making referrals, this is an important part of care in general, but when we think about it from a sexual health or sexuality standpoint, we want to make sure that the referrals that we are providing are trusted services, and that we, know who we're making referrals to. So do some research, make sure that whoever you are referring students to, that their values align with your values and the values of your university and your student health center. We certainly don't want students to experience trauma as a part of that referral process. But then it also, once we get to know those referrals, it helps with that warm, sort of handoff with students who are getting a referral. Update this information regularly. I'll talk more about that here in a minute. But you might also consider inviting the referrals to campus so that students can get to know them, maybe at a health fair or another community, organization event. So then it just helps to make that referral process a little bit easier. And the other thing that I want to note about making referrals, and this is important to think about, even for on-campus referrals, is sexual violence disclosures. So think about what do you have to report? What do the people you are referring to have to report in terms of those Title IX disclosures so that you can make sure that you're referring to the appropriate, people, and then letting students know ahead of time what might need to be reported. Next slide. And then evaluation and assessment, this is an important part of any work that we're doing, whether it's sexual health or not. But in terms of sexual health, some things to think about, benchmarking best practices, thinking about evidence-based care or evidence-based, education and programming versus evidence-informed programs. So evidence-based, has research to show that it's an effective program or strategy. Evidence-informed might be that maybe it was studied with a different population and we're using the research to inform what we do. It might not be sort of an exact or direct, correlation or, population. Implementing campus-wide surveys like the National College Health Assessment, and then evaluating student health services. We can't say if the care that we're providing is good or beneficial to the students if we aren't evaluating that and assessing it. And then also making sure that you're closing the loop. So you've collected this data, now use it. use it to improve your services, share the data with students so that they're aware of what's happening on campus and what other students are experiencing. I'm thinking about the MCHA, for example, and the sexual health behavior questions. So make sure your data is not just sitting in a file somewhere, but that we're actually using it. Next slide. And Blake had talked about in the beginning about wanting to make sure that we are providing some, information that's COVID specific. So I want to take a couple of minutes to talk about this. So when we're thinking about, privacy and confidentiality, that's going to look very different in a telehealth visit versus in an exam room or in a clinic. So asking and assessing that privacy during those visits, as well as during workshops, maybe asking people, what language can I use? Are you able to use these same language and words? Are there other people in your room? So asking questions, and that can help you to determine the type of information that you share and how much you share with the students, and then know how much they're able to share back with you. I talked before about adding your pronouns to your Zoom or WebEx name. Thinking about and acknowledging the risks versus the benefits in different prevention strategies for COVID-19, as well as for sexual health and safer sex. So for example, before the pandemic, we might have talked a lot to students about some of the risks as well as the benefits of sexting, for example, or other internet-based sex and sexual behaviors. And during COVID, those risks and benefits are going to look very different, because certainly it's much safer to have telehealth or telesexual practices or sexting or other computer-based sexual health behaviors or sexual behaviors. In terms of that risk of COVID, it's going to help to reduce that risk. At the same time, there might be risks for things like sharing that information and that those pictures and things going places we might not want them to go. So making sure that students understand that those risks and benefits are going to look different during COVID, and then they can determine for themselves, what they're willing and what they're comfortable engaging in. Talk explicitly about masturbation and sex toys. When we think about COVID prevention, things you do on your own in the privacy of your home or your room certainly is going to reduce the risk for COVID-19, as well as incorporate things like pleasure, which we had talked about before, and masturbation and sex toys when done alone, or even mutual masturbation with a partner, are lower risk activities for things like sexually transmitted infections and pregnancy. So talking about this, normalizing it, encouraging students to engage in it. And then updating your referral list more frequently, because those referrals might look differently during COVID. Some of those organizations may or may not, be able to serve students in the same capacity as before. So making sure that you're updating your referral list to reflect that. And I'm going to turn it over now to Blake to talk about health promotion.
Okay, thank you. So interesting. I love my job. So health promotion, this is a huge topic. Next slide, please. But again, we're going to try to read the document yourself. But I'm going to try to be as concise as possible. So health promotion, what are we talking about? We're talking about expanding campus strengths and protective factors while reducing risk factors. And then really, according to the World Health Organization, addressing the root causes of those various health conditions. So just remember, health promotion is collaborative. It's not one health educator, trying to educate everyone across campus. One person could do a program and reach 25 students, or someone could try to change a policy and get a policy changed and reach all students on your campus. And so we're really talking about taking that environmental approach to where it's not just about health education. So we have to do more than coordinate peer education programs. So, how can you involve students in these strategic initiatives that are evidence-based or evidence-informed to improve the health of your campus? Staff, we can do a lot when we try, but I don't think students recognize the power that they have. And so whenever students organize and they say they want something, they usually get it. And so, empower them to advocate for their sexual health. And going back to the environment piece, you know, how can we make the healthiest choice? Because, you know, we're all about self-defined wellness here. So the healthiest thing for one person, as they define it, how can we make that choice the default choice? Next slide, please. So in sexual health promotion, which again, this is in the ACHA standards of practice for health promotion professionals, but we want to use the socio-ecologic model. So looking at those individual, interpersonal, community, organizational, societal levels to affect change. We also emphasize primary prevention, which is, you know, preventing that poor health outcome before it occurs. So we want to use universal prevention selected and indicated. So if you're not familiar with that, just really quickly, universal prevention is, you know, an entire population. So let's take HIV for an example. You're going to educate all students when they get to campus about HIV prevention education. If it's selected, that's more maybe population specific if they have specific risk factors or a higher risk according to epidemiology. So that might be for HIV, gay and bisexual men or trans women, maybe having a peer-led outreach team by and for gay and bisexual and other men who have sex with men on campus. And then indicated is interventions for those students who have known risk factors. So someone's in a clinical setting, or let's say they're in I know a lot of health promotion professionals also do health and wellness coaching. Maybe they give some brief behavioral counseling when they talk about their sexual health risks. And so that's an indicated prevention strategy, right? So we want to, again, address all levels of that model and focus on the campus life and environments in which students live, work, and play. So it's not just on campus. You know, what about their res halls? What about the bars around them and the spaces where they hang out? You know, how can we think about space and try to design those spaces to be healthier? And then, of course, I already said it is collaborative. So again, yeah, work with all the stakeholders if you want to get something done. One easy thing that you could do, well, I wouldn't say it's easy, but one intervention that you could do is, especially in the era of COVID, conduct a sexual health environmental scan. You know, you can create a Google map really easily. You find some website to create a short link for that map, and you can promote it so many places. So, you know, at UC Davis, we have our student, staff, and volunteers every other year go around the community, like campus and the surrounding community, and say, where can people access emergency contraception, pregnancy tests, menstrual products, safer sex products? Where can they get themselves tested? And then we put that on a map so that maybe if our student health center is closed, they can go to that map and maybe find a place where they can access them. Another example might be collaborating with clinical stakeholders to implement testing reminders in the electronic health record, so that whenever a patient comes in and they see maybe you can set it up to flag if there's not a known HIV test on record. It can be flagged to ask them for an HIV test. Or maybe you could just implement an opt-out testing policy, which is actually what the CDC recommends, where everyone who comes in is offered an HIV test or is given an HIV test unless they decline. Yeah, offered an HIV test, because people can always decline, right? Next slide, please. I do want to say one more thing actually about that. We do want to always center health equity at all levels of that model. And, you know, we do know that universal interventions tailored to the needs of those most marginalized will have the greatest impact for all students, right? So something else, this has really been a huge topic as we have moved into the COVID era, is safer sex product availability. So we have to invest in inclusivity. I cannot tell you how many times I see students only getting free External condoms. Well, penises and external condoms are not relevant to the types of sex that every student has. And so we need to make sure that we're being inclusive. We're offering non-latex products, dental dams, all kinds of products. And then always getting student feedback, of course, on those delivery methods. Next slide, please. So we know that these programs have been proven to increase condom use, prevent STIs and HIV, and save money. So the preferred method to distribute them is free. I don't like low cost. I would rather say for a cost, because I don't think we should make judgments about what is low or reduced cost for students, especially right now when many are facing basic needs issues as far as, food insecurity and housing instability. So I just wanted to say that. And then make sure that your products are available in multiple locations. So consider balancing between private and public spaces. Public to reduce stigma and normalize students seeing other students get free products or get safer sex products, but then some private spaces, of course, for those students who need them. Publicize widely to students. We'll talk about social media here in a second. Many distribution models have changed since COVID, but we're going to start trying to do, we're working on how we're going to do like a safer sex drive-through or a bike through, where students, we have those like those like grabber claws that are pulled, like the handles, and we'll just like grab a bag and then like hand them through like a car window or something. So we'll see. Our students come back in like a week, so we'll plan it then. But then mail order, a lot of places are going toward that model right now. And then peer-to-peer, which might not be COVID friendly right now, but definitely a model, because we know anything peer-led and peer-driven is going to be successful, right? Most successful. Next slide, please. So social media. Use social media because you can reach a lot of students that way. As I was talking earlier, you can reach one presentation or reach 25 students with one presentation maybe, but you could reach thousands with social media. So look through the guidelines more about how to do that in an evidence-based way, but ultimately use positive, empowering, engaging content created by and for students, obviously. Make it funny. Don't make it super serious to where they're not going to want to engage with it, or but don't be so funny that it's like that it misses the message, right? We don't want to be stigmatizing. Always analyze your metrics. It's super important, especially if let's say health promotion folks can show their leadership that they need a communication team because they're getting all these impressions and they're reaching so many students on social media. So yeah, any way that you can engage with students, whether that's through memes or using polls and question stickers, go for it. Next slide, please. So some really quick pandemic pearls. So just remember, you have valuable knowledge. Always provide feedback about your campus COVID-19 policies, even if nobody asked you. I know sometimes across the country right now, anyway, maybe not everyone is asking you. And so, but you have the expertise to review those policies and say, how can this be more student friendly or something like that. One thing to make sure that I would recommend is, what does your COVID amnesty policy look like? Or do you have one? If students say that they were sexually active with someone during and weren't socially distant, what measures are in place to make sure they have the space to be honest without punitive consequences? So you got to give students that space. Also, your job now is not to tell students to not have sex. We know that students are still going to have sex, and we just need to make sure that they have tools to stay safe. I think a lot of times right now, especially with these messages around perhaps masturbation and really emphasizing pleasure on your own and toys, a lot of these COVID-safe sexual health measures that some institutions have been promoting have been very stigmatizing, and they've been really laughed at in a stigmatizing way nationally. And so, you know, we need to look no further than the HIV epidemic to see what stigmatization of people who are sexually active and just stigmatization of sexual health can do to a community. This is still a matter of life and death, and, you know, it's no laughing matter. Also, seek out new partnerships and abandon the status quo. So this is the time where you get to be creative. We can give you as much information as we can and say, here's this document that was written pre-COVID from our best practice guidelines, but you know, you have the knowledge and skills, and people are really learning from each other right now. So just use your networks and your students to be creative. And then also, you know, work with your clinical staffs to adapt their new policies and services, whether that is new STI testing models or PrEP delivery, something like that. And then finally, one idea, move your educational pamphlets online as a PDF, or create a YouTube channel. We actually did a poll on UCD Love Lab, which is our sexual health account, and or on Instagram, and over 100 students responded, and 98% of them said that they would rather have videos that they could watch on their own time rather than live Zoom programming. I think a lot of people are zoomed out right now, and you know, that's just one response from one sliver of our audience that we got at UC Davis. But ask your students what they want so that you're not wasting time doing all these evening Zoom programs when they don't want to have them. Thank you. That's all. Next. And now Joanne to talk about
Thanks, Blake and Brandy. So as I discussed the clinical care aspect of best practices, although I'll strive to be inclusive in my language, some of the language used might reflect standard clinical language that's used in national guidelines. So that's a little caveat there. Next slide, please. So sexual health is integral to general health. It's associated with happiness, well-being, and longevity. So we really need to be proactive in addressing it with our patients. Taking a routine, comprehensive sexual history may help direct our next steps by helping to explain somebody's current health problems or determine their need for primary prevention, such as immunizations, contraception, PrEP. But I understand that not everybody feels comfortable taking a sexual history. So a couple of ways to start the conversation might be saying, sexual health is really important to overall health, so I ask everyone these questions. Or I'm going to ask you some questions that are important to your medical care and well-being. Everything you tell me today is confidential. In the box at the bottom of the screen are a couple of resources to help you if you're not feeling comfortable taking a sexual history. It's got some good scripting and some other key points. I will acknowledge, though, confidentiality, as Brandy and Blake both mentioned, confidentiality in the COVID era might pose some challenges, particularly when conducting telehealth visits from dorm rooms, apartments, or back home, maybe with mom and dad in the next room. We really want to ensure that our patients are in a safe space to answer and ask those questions openly and honestly. So again, asking some of those languages, ask them who's around, are you in a safe space? Can you, do you have some privacy? If you have concerns or they're afraid of being overheard, you can ask them to write questions and their responses in the chat box. I suggest to my patients that they use earbuds or headphones, or particularly if they're home or in an apartment where the walls are thin, that they have a noise machine playing in the background. I've had students doing telehealth visits from their cars, as it was the only private space that they had to talk, which is okay as long as they're not driving. I've had to have 2 of them pull over and park and call me back. But I've had a number of patients talk to me from an outside space, which is beautiful, or in their cars. So try to be creative and just try to think about that as you're doing this. Next slide, please. So one approach to sexual health history is to use the 5 Ps approach outlined by the CDC. I really like the 8 Ps approach that was presented by the National LGBT Health Education Center or Fenway Institute. It adds preferences such as asking about preferred language the person uses to refer to their body parts. It asks whether they've ever used hormone therapy or had gender affirming surgery. It includes questions about pleasure. Excuse me. Like, are you able to become aroused during sex? Are you having any pain or discomfort during sex? Are they satisfied with orgasm? And it asks questions about partner violence. Has anybody ever forced or compelled you to do anything sexually that you did not want to do? Which I think are all important things to those 5 Ps. Next slide, please. I'm going to try to take a drink here. By age 45, more than half of all American women will have experienced an unintended pregnancy. So one key question is a simple screening tool that can be used to facilitate a conversation with your patient regarding pregnancy intention. It's designed to help identify the preventive reproductive health care needs of our patients and really focus on the patient's goal for their own health, not just our goals. It's not just for females, but it also applies to people with a penis and our transgender non-binary patients. So you could ask questions like, are you currently trying to conceive or father a child? Or are you concerned about getting pregnant or getting your partner pregnant? And then based on those responses, ask about contraceptive use and provide information if desired. And certainly encourage folic acid supplementation for those that are desiring pregnancy or those that might not be using reliable contraception who are capable of a pregnancy. Next slide, please. USPSTF recommends screening for intimate partner violence universally using an instrument that accurately detects IPV in the past year. There are some examples of different instruments in the box, in the black box at the bottom of the screen. It should be done in private and at least annually, and those with a positive screen should be referred to appropriate agencies and provided that ongoing support. So think about the importance of developing those relationships that Randy talked about with the agencies and keeping that list updated. You know, we discussed some issues with confidentiality when asking those sexual health history questions. So the same applies here, just think about it. So think in advance how you might address this and think about, you know, really how do we keep our patients safe from violence during COVID? Because we know those calls to hotlines are going up. So we really need to think about how can we do this and how can we address it a little bit better. Next slide, please. So while limited or insufficient evidence exists to support doing routine pelvic exams or doing comprehensive physical exams for those patients that don't have any symptoms, having an annual wellness visit really provides an opportunity to ask about behaviors that might increase risk for sexual issues and provide some of that education and counseling. We ought to be asking about vaccinations such as HPV, Hep A, and Hep B, and recommending that they, for those that have not been previously vaccinated or did not complete the series, that they complete it or get it. Current guidelines recommend starting cervical cancer screening at age 21 for anyone with the cervix, regardless of sexual activity. You'd want to use a smaller or pediatric spectrum for those who have not had penetrative vaginal sex, or somebody who might be transmasculine on hormone therapy, etc. Since 2011, according to the Sexual Health Services Survey, between 45 and 53% of college health centers report that the cost of all STI and HIV tests are charged to the patient or their insurance, which might, as Randy mentioned, unintentionally reveal information to policyholders such as parents. So it's really essential that we think about some of the options to address confidentiality in providing those services. So please consider offering STI HIV screenings at no cost or at lower cost so that students might be better able to pay for them out of pocket. Remind students not to share passwords that might link to their health information if they can avoid it. And make sure students are informed about those privacy practices and HIPAA. And as Randy discussed, educate them about state confidentiality laws and insurance. Next slide, please. Doing site-specific screening for STIs should follow CDC and USPSTF recommendations and done regardless of one's sexual orientation or gender identity. And these recommendations really highlight the importance of that sexual history, because if we're not asking the questions, we won't know what to screen or where to screen. It's important to ask those 3 W's, like what, where, and then screen the appropriate anatomy. I just attended the CDC 2020 STD Prevention Conference last week, and there was a great discussion about providing annual screening for chlamydia in young adults, particularly young women, regardless of sexual history, because providers are not asking the questions to assess their risks and determine the need for screening, or patients might not be answering them honestly. So I'd like to hear more about this. I think it has a great potential to impact the dramatic rise we're seeing in STI rates. And so I look forward to more debate on that strategy. Research shows that self-collected vaginal swabs are patient preferred and just as reliable as clinician collection. They're also appropriate for use for rectal specimen collection too. Any STI screening should also include HIV, and CDC, as Blake mentioned, recommends everyone ages 13 through 64 be tested as HIV as part of their routine care at least once in their lifetime and annually based on risk. And it preferably should be done for an opt-out option where patients are informed they're going to be tested unless they decline. We also know that STIs facilitate transmission of HIV. So if it's not been already done, anybody that you're seeing and treating for another STI like gonorrhea, herpes, or syphilis should definitely at that time be offered a test for HIV. Next slide, please. So CDC released guidelines in April 2020 for flexible and practical treatment options for STIs when in-person visits are limited or disrupted. These include the use of teletriage or empiric treatment based on symptoms such as urethritis, vaginal discharge, or genital ulcer disease. In cases where the preferred treatment might be intramuscular, but only oral medications are available because they can't come into the clinic, patients should be counseled to follow up if symptoms have not improved or resolved within 5 to 7 days. I'm sure you've seen this, we've seen it as well, but all over the country, starting in March, utilization of all preventive health services was down, including screening for STIs and HIV. Although screening and treatment has started increasing again, we're far behind our usual numbers. And then on September the 3rd, CDC published a memo discussing a potential shortage of NAT test kits. If this is affecting your area, they recommend screening women younger than 25 only if they report sexual activity, and women older than 25 only if they have risk factors such as a new partner or STI reported in a partner, and not screening extragenital sites in women. For MSM who report sexual activity, they recommend doing rectal testing instead of urine if test kits are limited. That's not a problem with you, test everything. But if you're having an issue acquiring those NAT test kits because of competition with COVID, those are some options. There are also a number of options for home-based testing through companies like NERCS, MyLabBox, Molecular Testing Laboratory, using telehealth visits to assess risk and provide counseling, followed by the use of home-based testing for screening is a really appropriate strategy. We've been mailing self-collection kits and then have students return them to a drop box outside our building or sending them directly to the lab after a telehealth visit. I'm really looking forward to our webinar in November because I think we're going to be discussing some other ways that our colleagues are adapting to providing screening. Next slide, please. Expedited EPT or expedited partner therapy is an important harm reduction strategy in the STI battle. It's the clinical practice of prescribing and dispensing medications to the sexual partners of patients diagnosed with an STI for things like chlamydia and gonorrhea without requiring them to have a visit with a healthcare provider. EPT is now permissible in 45 states, but 26% of respondents to our 2019 Sexual Health Services survey in states where it was legal said that they didn't prescribe it. And another 6% were not sure of the status in their state. If you're a college health professional, I really encourage you to research the legal status of EPT in your state and the policy in your clinic, and to advocate for its use, because we have to do something about our rising rates of STIs. Next slide, please. We have 2 opportunities to dramatically reduce our students' chances of acquiring HIV if exposed. Clinicians ought to be proactive about discussing and offering PrEP and PEP and sharing information about their availability through our health promotion colleagues. ACHA PrEP guidelines released in 2019 is a wonderful resource, so I'll direct you there. Next slide, please. The CDC released a Dear Colleague letter in May encouraging providers to continue providing these services during COVID-19 and outlining some of the options, including the use of telehealth visits and home collection kits. And if for some reason a clinic's not able to continue providing PEP and PrEP, they need to make sure that they develop a referral system for this really life-saving care. Next slide. And any discussion about clinical care, particularly during this time in our country's history, would not be complete without highlighting health inequities. We know that Black, Latinx, and Native American people face increased maternal morbidity and mortality. Women from racial and ethnic minorities are less likely to use effective contraception than white women, and Black women are less likely to have HPV vaccination. We as healthcare providers need to recognize the ways in which we and our healthcare systems perpetuate these unacceptable inequities in access to care, which affects their outcomes. We know that racism and implicit and explicit bias may negatively influence access to prevention, testing, and treatment, and they're amplified even more so when there are shortages in medical supplies, equipment, and staff, as we've seen in the last year. So while we all shift the ways in which we're providing care, we need to plan and implement telehealth with those who already face health inequities in mind. So what additional challenges does this pose for them? Does everyone have access to reliable internet? Could we use phone calls as an option or come up with some other strategies for outreach? Next slide, please. So this slide just is a quick review of some of the pandemic pearls that we've discussed, such as using telehealth, which I'm sure most, if not all of you, are already doing. I'm really interested into learning how you all are dealing with some of the challenges that I know I'm facing in my practice. So how are you providing care for students who are taking online classes from their homes in another state? We've been mailing those self-collection kits for screening following telehealth visits, but we've experienced some big delays from the Postal Service. Some clinicians question what's appropriate to see via telehealth, and what do you do with the patient who wants to show you the spot on their genitals? Should we have chaperones for telehealth? I'd love it if y'all would share how you're adapting to these challenges, either in the chat box or Q&A and on ACHA Connect. I love how we can all learn from each other. We've got some good folks lined up to discuss some innovative ways they're adapting in November, and we hope to see you back with us then. And that's it. Next slide. And I think this is back to Blake or Claudia.
Sorry, folks, that's me. And thank you, Joanne, for that wonderful segue. So as we discussed before, in the coming months, ACHA, through the generosity of Hologic, will be publishing a toolkit. And that will assist member organizations in implementing these best practices. Starting all the way at how you organize your stakeholders on a campus and moving through the real nitty-gritty of the steps that you need to take to make those changes institutionally. So this toolkit really will be a roadmap for how to move forward. So stay tuned for that. That will be coming later this year. And as Joanne mentioned, we've got another webinar coming up on November 13th. And we will be featuring case studies. So we'll be talking with 3 campuses who have implemented either one or several of the best practices to learn what went well, what didn't go so well, and keep an eye out on your email for registration for that webinar, which will also be free of charge. Thank you to Hologic. And now I think the fun part begins and we get to do Q&A. So we have some questions that we can put out there, but if folks would like to type their questions into the Q&A box, we can read them and open it up.
I'm going to put something in, I guess, in the chat box. I got a question earlier about kind of what's appropriate to do through telehealth. There are some great resources, and obviously I think I highlighted some of the things as I was talking about it, but I'm going to, I think I did that. Yeah. So I just put some resources for people in the chat box.
Great, thank you, Joanne. And it sounds like we have a question, again, for you, Joanne. So let us say that you are doing a telehealth visit and you are observing some problematic behavior or worrisome behavior in the background. How might a clinician respond to that in a way that is responsible and responsive.
I guess it would depend on what's going on. I will before, because I've seen people like in the background going back and forth, and again, I do mostly sexual health, and so I have stopped the person and said, so who's in the room with you? And then and then they had earbuds in, so I felt safe there, but I might kind of type in, or I might say, you know, it looks like there's something going on right now. Are you safe? I guess that's one of the things. And we just said, we have another, it looks like there's another question that I think I'll go follow up on. It's like, how can you go through a prep visit? So one of the things that I do, because I do teleprep all the time. And if it's a new somebody new interested in starting prep, I'll have a telehealth appointment with them first, and then I'll order the labs and they'll go to the lab, and then I usually have kind of a follow-up appointment with them that you could do based on what their responses were to your questions at that visit. You could do same day start easily as well. But for my returning patients, I actually have a reminder that goes out to them at like 75 days that says, hey, here's so much time for you to renew your prep, contact Joanne. And so I order the labs and they go to the lab and get them and then follow up with me via telehealth. And the students are really responsive to it and really love it. And then if they need other STI tests, I send them out the self-collection kits, or they'll drop by my clinic and we'll have them provide the sample really quickly. Hope that answered that. Okay, I think we have some other ones in there.
Thank you, Joanne. I see we have a question about how to run a mailing program for a safer sex product. So what's the best kind of packaging? How do you do that?
I'll take that one. I answered it in briefly in the chat, but so the condom fairy that was mentioned, that's the mail delivery program. That one actually has been studied. They've done research on it, and I dropped the research article in there. Can you all see the answers to the questions, or do I need to put that in the chat? I'll just put it in the chat. How about that? So there's a research article on the condom fairy. That might have some insight. Yeah, check that out.
And for those of you who do have, inter-office mailing on campus, right? I think making sure that things are, reasonably padded so that they don't get too beat up can be helpful, but not overdoing it. But I know we just used inter-office envelopes with some extra paper or cardboard from our recycling, and that often did the trick.
I realized I was typing and didn't have myself muted. I think Alexandra had a little bit more of a question. One of the things that we talk about at Margaret Hyam at Tufts when we were writing the PrEP guideline, I think was really good about this. It's like, I liken it a lot to birth control pills. I don't want my students to run out of birth control pill refills either and have an unintended pregnancy. I certainly don't want my patients who are on PrEP to run out of their PrEP medication and have an unintended HIV infection. And so I really have been a little bit more flexible with the timing. If they've not been able to get in right in time, I might give them an extra month of PrEP and let them get their labs afterwards, because I don't want them to have that gap. And I think that would be really appropriate. The other question that I have, I think for me, is how do you do a vaginitis or UTI telehealth? That's one that actually CDC had recommended, that there are several things that, definitely based on somebody's symptoms. If you look, there's a couple of good studies that have been out there saying that someone who has previously been diagnosed with a UTI, who presents with symptoms of a UTI, has a really high positive predictive value, regardless of what their urine dipstick shows and whether I see them in clinic or not. If somebody who has previously had a UTI has a telehealth appointment and says, I think I have a UTI and I'm having XYZ symptoms, I'll ask them other questions to make sure that they don't have pylo. I'll have them stand up and say, okay, press on your suprapubic area, press on your lower abdomen. Does that hurt? I would say, bang on your back. Are you having CVA tenderness? And if they're not febrile or whatever, we will treat empirically and then tell them, but certainly if things are not getting better in 24 to 48 hours, then you need to come into the clinic and see me. but certainly that's something that you can do empirically. Same thing with vaginitis. You know, you can tell a whole lot by somebody's history. And so if somebody tells me they're having itching and irritation and thick, chunky discharge, I'm gonna say, you know, it sounds like you have a yeast infection. Let's try this. But if that's not better, then you'll need to come in and see me in person. So and again, asking those questions, and again, I'll have them palpate their lower abdomen to make sure that they're not having any pelvic tenderness or abdominal tenderness. All right, I hope that answered it.
Any other questions, either in the chat or the Q&A? We are open. We can also put it out there for folks in the audience to answer some questions. Does that sound like a good idea? Great. So I know one of the things that we're all curious to hear about is what kind of barriers have you encountered in addressing sexual health during this most recent semester? So some of you, I know Blake is not quite back yet, but some folks have been back for a little while. So what are the barriers you're encountering? And you can either chat them or put them in the Q&A. I know we had a question at the beginning about anticipation of pushback from administrators about the kind of content you're putting out there, especially about pushback.
Claudia, while people are responding in the chat room, I'm going to just respond. We had a couple of questions that we got in advance.
Okay.
As people were registering, and one of those questions was about what forms of sexual activity result in highest rates of transmission, like namely what bodily fluids are known to carry COVID. Mm-hmm. And another question similarly saying, should people get asked for a COVID test before they had sexual activity with a partner? So we know that COVID is spread by respiratory droplets and saliva. So there's not any evidence of spread from semen or vaginal fluid, but the virus has been detected in semen from people diagnosed with COVID. It has been found in fecal matter. So behaviors that involve sputum or saliva, so kissing, and activities that might involve oral to anal contact, like rimming, might spread COVID. If they're with a partner and a finger goes in some partner's mouth or something and then goes onto that person's face, that certainly, you know, they touch their eyes, that certainly could be a way that COVID could be spread as well. I think rather than recommending that you show me your negative COVID test before we have sex, because that only shows really one point in time, I don't think that that's going to be very efficient. That we encourage our patients to have sex with somebody that they're already in contact with. So develop a buddy, or like somebody that you're in your cohort with, somebody that you're hanging out with already. You're in your class with them. They're in your dorm, they're in your group, because you're already in contact with them, with that person, versus just a random hookup, somebody that you meet just on Tinder or whatever. Brandy, you have anything to add about that?
No, I'm sorry. I'm reading all the questions. Y'all have some really great questions.
It sounds like there's a lot of focus on, we've got all these great supplies, but they're not where the students are. So either our students are off campus and aren't coming in right now, or we've got these great dispensers. We spent so much money putting in dispensers. I know that pain, and no one's allowed in that building right now. So the trick of really getting the supplies to where the students are. So I'm wondering if folks have other strategies besides mail and condom ferries.
I can talk a little bit about what we do at the University of Cincinnati. So Blake mentioned we have a peer-to-peer program called Gotcha Covered, where we train other UC students who live with UC students to help to distribute condoms. We have much lower participation this semester, but we have had some students still express interest. It's usually RAs. And we've been talking to them about how can they distribute condoms in a way that, will not transmit the virus. And so people have lots of different strategies that they've used. Some RAs put them in a basket in the bathroom, you know, like in a common restroom in the residence hall. So then that way it's a little bit easier for students to get. Of course, one of the downsides to that is they don't get that safer sex messaging, you know, and information that we try to incorporate in our, you know, when we distribute condoms. But from a COVID standpoint, you know, it's certainly lower risk. When we get with some of the condoms that we get, they come with like a little like handout on how to use them. And so we've been providing those with the Gotcha Covered volunteers as well. So then they can put those with the condoms. There might also be, you know, some RAs will put, or some of the volunteers will put like a cup, like pin a cup to the bulletin board by their door and put condoms in the cup. Certainly not pinning the condoms to the bulletin board, of course, but like some ways that people, you know, without having to interact with each other and without necessarily having too many hands in a bowl, you know, but my thought is students are going to have sex regardless of the risk for COVID, and I would rather they have condoms to help to reduce their risk for other things, you know, at the same time. So it's sort of like balancing those risks that we had talked about before, the risks and the benefits of different, you know, safer sex strategies during COVID. So there might be some other ways.
Can I say one more thing? I know it's one. I know it's one. So first of all, thank you all for all these awesome questions. I wish we could talk for like another hour together, but you can always email us. But one partnership that we're going to try out, we already partner with them, but as far as safer sex product distribution is our Basic Needs Center. So they're actually going to have basic needs care packages that they mail out every other week or so. And so we're going to supply them with pre-made bags of safer sex products with a QR code sticker, to where with sexual health information on our website, basically. And then they will mail that out to students. So that's one way it's going to get out there. But look into your Basic Needs Center if you have one.
Thank you so much. I know we could keep talking for a long time, especially this crew. We've got a lot to say, but thank you everybody who's joined us this afternoon. Thank you to our fabulous speakers, Joanne, Blake, and Brandy, and thank you to Hologic for sponsoring this webinar. Thanks to all of you who joined us today, and we look forward to seeing you again on November 13th, and have a wonderful day and weekend, everyone. Thank you, bye-bye.